I have received study funding through Medtronic, but have no other relevant financial relationships. And I will be discussing many different pumps and insulin sensors, glucose sensors, which are not FDA approved for young children. Today for the talk, first, we're going to discuss the differences between type 1 and type 2 diabetes diagnosis and epidemiology. Next, we'll identify some of the common methods and pitfalls of blood glucose monitoring. Then we'll talk about differences between traditional insulin pumps, closed loop systems, and looping. And then finally, we'll talk about some of the upcoming advances, including early screening and prevention therapy for kids with type 1 diabetes specifically. So to do so, we'll talk about the diagnosis first, followed by glucose sensors, pumps and loops, and then the category of research, advancements, or other sweet stuff. So first, kind of look at the frequency of type 1 diabetes compared to other chronic disease. When we look at common chronic diseases of childhood, type 1 diabetes is by far one of the most common, affecting up to 3 per every 1,000 children, with a rising population of children that are also developing type 2 diabetes. But when you compare it to other kids with severe asthma or IBD, leukemia, it's definitely a significant chronic disease of childhood. A common first step in managing type 1 diabetes is recognizing it. So when we look at the definitions, please remember these numbers and that they'll really be important for treating and identifying these kids. An important thing to remember as well is that it's never normal to have an abnormal blood sugar in a child. So even if the child is sick or stressed, it deserves follow-up because oftentimes diabetes can be subtle and first be manifesting in some isolated impaired glucose tolerance test, followed by then fulminant diabetes thereafter. So when we're looking at diabetes, the definitions are first, having a fasting blood sugar greater than 126 milligrams per deciliter, about 7 millimoles per liter, having a random blood sugar greater than 200 milligrams per deciliter, about 11 millimoles per liter, or any hemoglobin A1C greater than 6.5%. Any of those meets the definition of diabetes. Then prediabetes is in between normal and diabetes. So any fasting blood sugar greater than 100 is technically prediabetes. If I were to look at one abnormal glycation measure, it's probably an impaired fasting blood sugar first, especially in kids with type 2 diabetes. Any random blood sugar, even above 140, is also considered impaired, or above 7.8 millimoles per liter. And then any hemoglobin A1C 5.7% or greater is technically impaired and does deserve follow-up. A big problem we're running into nowadays, especially with the pandemic and rising rates of obesity and weight gain, is what kind of diabetes are we dealing with? It can be really difficult to distinguish between type 1 versus type 2 diabetes. Some of the problems in that of children with type 1 diabetes, mirroring the general population, about 30% have a BMI greater than the 85th percentile for age. Likewise, 25% of kids with type 2 diabetes present first in diabetic ketoacidosis. And you might wonder, well, why is that? And the reason is that, especially in teens, you get enough hyperglycemia to have toxic stress on the beta cells. And instead of having insulin resistance, you can actually, these beta cells can be so stunned that they have failure to produce insulin because of chronic glucotoxicity and result in diabetic ketoacidosis. And actually, of teens with type 2 diabetes, about that 20% really have significant DKA at presentation, and it's very different than adult type 2 diabetes. Other things is that when we talk about the diabetes antibodies, they're decent for diagnosing type 1 diabetes, but they're not absolute in that in the general population, it's been estimated up to 15% of kids with type 2 diabetes have at least one positive diabetes 1 antibody. Usually it's a GAD65 that's weakly positive, but there can be others. So it can be kind of muddy. So how do we actually decide between type 1 versus type 2 diabetes? Oh yes, and of people diagnosed with type 2 diabetes, 10% are actually found to have type 1 rather than type 2. So it's muddy. So what do we not base it on? One is the rate of progression. Oftentimes, type 2 diabetes in teens can be very different. Because of all those sex steroids, you can have a fulminant rise in your A1C over months. I think about a patient that had an A1C of 6.2%, had a weight gain during the summer. His next A1C, true type 2 diabetes, was 12.3%. So unlike adults, where there's a slow progression of impaired glucose tolerance with type 2 diabetes, and adolescence is different. Once you hit this kind of critical tipping point, it's very easy for them to have a sudden escalation in their A1C, and even, as we said, resulting in DKA. The other part that can be difficult is family history. Nowadays, there's so many family members that have diabetes, and it's unclear if it's type 1 or type 2, that tends not to be reliable. It can be helpful if there's a family history of other autoimmune diseases like thyroid disease or celiac disease. That tends to run a little bit closer together with type 1 diabetes, but again, it's not absolute. What is helpful is any child less than age 10, that's probably going to be type 1 diabetes. And the reason is that it really takes the combination of excess adipose tissue plus sex steroids in puberty to achieve type 2 diabetes. So for the child less that's also likely going to be type 1, is that it takes some degree of adiposity to have type 2 diabetes. And then we talked about one antibody can be equivocal. Having 2 or more autoantibodies is type 1 diabetes. And so a little bit more about what these antibodies are. There are 4 antibodies that we typically measure here at Mayo Clinic for diagnosing type 1 diabetes. The availability is a little bit different center to center, but in general, we are more and more measuring all 4 of these antibodies to help us decide, is it type 1 or type 2, or as we'll get to, monogenic diabetes, that's a single gene inherited that's not type 1 or type 2. On the top left is this glutamic acid decarboxylase. It's the most common one seen in adults, or GAD65. It's commonly seen to have a weak positive, but a strong positive is more suggestive of type 1 diabetes. The insulin-associated protein 2 levels predict earlier age of onset. It's first in younger child, and higher titers have earlier disease. And insulin treatment, though, can generate these antibodies as well. So it's important to remember, especially when we're checking insulin antibodies, that exposure to insulin can raise the antibodies. And lastly, the ZNTH is the one that we see most, I think, closely associated with type 1 diabetes. So to summarize the diagnosis section, we diagnose it based upon labs. Any fasting blood sugar greater than 126 or 7 millimoles per liter is diabetes. Any random blood sugar greater than 200 or about 11 millimoles per liter is diabetes. And any A1C greater than 6.5% is diabetes. Other pearls to remember from the diagnosis section is that type 2 diabetes can be progressive and can have diabetes ketoacidosis. And we really think about type 1 if you have a child less than 10, a child with diabetes but has a BMI for age less than the 85th percentile, or 2 or more positive antibodies. So our next section then, we'll talk a little about glucose sensors. Glucose sensors we commonly call CGMs, abbreviates for continuous glucose monitor. And the way these work is that there's a device that sits on the child's skin and a catheter that goes into the interstitial fluid. So I always tell my patients it's nothing sharp that will stay in them. It's really just a very thin filament that stays in that measures the glucose in the interstitial fluid and extrapolates what the glucose is in the actual blood. An important thing to remember that we'll talk more about is that when we look at the rate of change, you'll see that the blood glucose will change a little bit before the interstitial fluid. Where this is really important is if the child having a big swing in their blood sugar. So say they're having a low, your CGM will recognize the low and also then see treatment of the low. It'll be a little bit delayed to the actual blood value. Here are some other methods for measuring blood glucose. Depends upon where you are in the world, but some of the measures here, this is the Medtronic Guardian Link that talks to the Medtronic pumps. This is a Dexcom glucose sensor. This is a Freestyle Libre here. And this is an Eversense that goes implanted into the arm in patients 18 and older. So lots of different ways to monitor the blood glucose. Some talk to different pumps, some last longer than others, but in general, it's based upon the same principles. For most CGMs, you have anywhere from a 7 to 14-day wear, and they really have become kind of the standard of care for especially children with type 1, but even now, children with type 2 diabetes. Some of the benefits is that it can go to multiple caregivers. So depending upon the CGM, and if you have to go to a phone or an app or a device manager for the child, it usually can be transmitted to multiple phones. So if the child is in daycare, the mom or dad can know what the glucose is on their phone. If the teenager is driving, the parent can know what their blood sugar is before they get behind the wheel, which can be generally beneficial in most situations. Some of the data behind CGMs that it definitely does reduce the severity of hypoglycemic episodes. There can be modest improvements in A1C, but it does tend to reduce glucose variability. Many questions we often get, well, how good are these glucose monitors? We look at a typical mean absolute relative difference of about 9 to 10%, with 93 values being within 20% of the true value by standard of care via an actual draw of the blood glucose. What that means is that if we look at a lower blood sugar, so 70 milligrams per deciliter or about 3.9 millimoles per liter, if that's the true blood glucose on a draw, your CGM could tell you it's anywhere from 56 to 84 milligrams per deciliter or 3.1 to 3.7 millimoles per liter. And actually that variation is pretty common also in point of care devices. So they're pretty equivocal compared to the standard of draw, but it's really important that we know that it's only about this good because we really only recommend using these devices for kids with diabetes because they're just not accurate enough to detect true hypoglycemia in children with lower blood sugars. And likewise, with a higher value, if your CGM is reading 300 milligrams per deciliter or about 16 millimoles per liter, that means the true value is anywhere from about 240 milligrams per deciliter to 360 milligrams per deciliter, or about 13.3 to 20 millimoles per liter. So there is a wide variation. It's enough for insulin dose decisions. But again, when you really want to know exactly what the blood sugar is, which is particularly important for non-diabetic hypoglycemia, CGMs are not the way to go. So it deserves a slide its own. Do not place a CGM for hypoglycemia in patients without diabetes. We have found clinically that they cause stress and anxiety. They're not that accurate. They're alarming when the blood sugar is normal. They're not picking up when the blood sugar is abnormal. And so as a practice center, we do not place CGMs for patients without diabetes-related hypoglycemia because it's just not accurate enough and hasn't added clinically to these patients' care. So a few things I'm going to show you though about CGMs. There's different apps based upon, but this is we use the most Dexcoms here in the United States. This is what it would look like is that the patients have their monitor. If it's transmitted to a phone, it can both go to other phones, but can be uploaded onto a computer. So during the COVID times with telehealth, this was a great way in real time. We can know exactly what our patient's blood sugar was. And some of the other benefits as well is that it really made pattern recognition easy. So this is one of my patients, and you can see here this black line is their average blood sugar and the standard deviation over time. So you can see they pop up with breakfast, come down, stay down, and they start to pop up overnight again. So that pattern needs a certain amount of insulin adjustments. Other nice things from these CGMs is most CGMs give what's called a GMI, or a glucose management indicator, which is essentially an estimated A1C based upon the readings it's taken every 5 minutes, which even during pandemic times, we used in lieu of a clinical A1C draw for patients hesitant to get outside the house for the lab, and generally work pretty well to inform patients where their management is at, even without having to have a blood draw. Another thing about CGMs is they vary brand by brand, but you really need to know what the alerts are. Particularly if there's other people relying upon an alarm to be on, know that most of these alarms can be turned on or off or customized. So just to really have a good understanding for all caregivers for the child or for in a clinical setting, what alarms are on and what alarms are off, because they can be programmable on the phone. Some of the pitfalls for CGMs. The first is that it can be difficult to keep them on. I personally have used them down to about 4 months of age. Typically, you need about 1 inch to pinch. So for most infants, you can get them on the sacrogluteal area or the thigh, but it can be difficult to keep sites on in younger children. Again, we talked about, but you're going to have a delayed reading compared to the blood glucose because you're sensing interstitial fluid. So especially with hypoglycemias, once you've identified it, don't keep treating until the blood glucose comes up on the CGM. Look at the point of care and wait for the blood to come up, because if you wait and keep treating, waiting for the CGM to rise, you're probably going to overtreat the child and they'll wind up with hyperglycemia as a result. There used to be more interferences with CGMs and acetaminophen. It's less so, but it's still important to know that it can potentially mess up the reading a little bit. And the last thing is that you have to have normal perfusion with euvolemia for the CGMs to work optimally because they are based upon interstitial glucose perfusion. And then lastly, they're not compatible around any MRI or electrocautery, so they do have to be off if you are in an MRI field. And then just know where the alarms are. All right, so to summarize the glucose monitoring section, neither blood glucose by point of care meter or CGMs are exact. CGM does improve the rate of hypoglycemia and decreases the glucose variability. Meters and CGMs do have a history, and it can be electronically downloaded so you can know what the patient does. All right, so we'll move on to a few notes about insulin pumps and loops. Here's some different examples, just showing you how child-friendly and hardy some of these different systems can be. This is a child up on the left with an Omnipod, showing you it's waterproof, it stays on pretty well. This is a tandem T-Slim, one of the advanced loops with a customized skin. These are Medtronic pumps down here. This is the Medtronic 670 talking to the Medtronic Guardian. So lots of different systems out there commercially available. Well, if I can stress one thing, it's having a pump doesn't yet equal a diabetes cure. They're getting better and better and better, but they still have quite a bit of user input and can lead to diabetes burnout distress if paired with the wrong person. Some people feel more technology, more work. It's estimated actually that the average patient with type 1 diabetes makes about 180 diabetes-related decisions per day. They do have a modest decrease in glycemic variability and a modest improvement in A1C. These are all, though, based upon traditional pumps, and with the newer advanced loops, I anticipate the data is going to be much stronger, supportive of doing pumps in these patients. And so what I mean by this is we've had a big progression in glucose responsive insulin delivery over the past years. So in the beginning, you had your glucose sensor and you had your glucose pump, and they were separate devices. But recently, now we have the first evolved of a threshold-based suspend, meaning that if the blood sugar is low, that the pump stops. Above that, then we have a predictive low suspend, meaning if the sensor is detecting the blood sugar is going to be low, it turns the pump off before the child has a low blood sugar. We moved on then to single hormone closed loop, where your pump and your sensor are talking to each other, what we have right now with insulin. And eventually there's some work of looking at dual hormone closed loop, where you have both insulin and glucagon in different devices to help really smooth out insulin delivery. So here's some examples of some of the commercially available single hormone closed loops. This is the Medtronic with the Medtronic Guardian. Here's the tandem T-Slim paired with the Dexcom. There are other ones coming out very soon in the Omnipod 5. There'll be more to add to the list pretty soon. The way they work is that the sensors and the pumps are talking to each other, and about every 5 minutes, depending upon each technical system, it's modulating the basal insulin delivery based upon both what the actual blood sugar is, the rate of rise or rate of fall. It also still has that threshold where it suspends if it's predicting a low blood sugar to avoid lows. And likewise, it has some missed bolus protection features, particularly with the new tandem T-Slim. So if a patient eats breakfast, they're busy, they're running, they forget to put their carbs in their pump, the pump recognizes, oh, Jimmy ate breakfast. Jimmy is rising fast. I know Jimmy needs this much insulin. And it still won't give 100% of the estimated bolus the pump thinks Jimmy needs, but it will still give 60% of an estimated missed bolus. So it's really becoming a nice feature, especially for teens, to have these missed bolus protective features, as well as all the different background adjustments for the microboluses. For patients that have not yet been able to afford, or insurance companies that won't cover these loops, there are even things out there common here in America, and I think outside as well, called do-it-yourself looping. So if you just Google DIY looping, we even have patients here at Mayo Clinic that do this as well. There's an app through Tidepool, and there's different ways. You just buy this Riley link online, and it links up pumps and sensors that typically don't talk to each other to an app on your phone, and then you can do a do-it-yourself looping, which actually works surprisingly well. I have a couple loopers that are quite happy with their looping arrangements. Some of the pitfalls for pumps is remembering that if there's a problem with the pump, Unlike patients on mixed daily injections where you have long-acting insulin that's still probably on board, there is no insulin the minute the pump is kinked off, which happens not uncommonly. If someone forgets to put their pump back on, they get a bad site, the tubing gets kinked. I can go on and on about the reasons why pumps stop, but just remember that as soon as there's a problem and the pump's not delivering insulin, pretty soon your bicarb will be falling fast. So lots of troubles with the sites, tubing, or even if the insulin is old. Another issue with the advanced loops is that it is still a more adult-based deep learning algorithms. It's becoming more and more pediatric friendly, but there are both weight and insulin unit cutoffs for these different systems. So for tandem t:slim, for example, you have to be at least 55 pounds to go into their looped mode. You can still use the pump in an old-fashioned way without being in a loop, but you have to be a certain weight and insulin daily delivery to really feel comfortable using the pump in these patients. All right, so to summarize the pump and loop section, pumps right now still don't equal easier diabetes care. They're great, they have a lot of really cool new features, but they take a lot of work. Single hormone loops are here, and we're very excited for all they hold for our patients, and that there's no residual insulin when the pump is off. So with these last few minutes, I'm just going to go through some of the other things that are coming up in type 1 diabetes. So other sweet stuff, we'll talk through this category. The one new area that I know is available worldwide is prevention. So we rescue many other organs with immunosuppressive before the organ fails. This is where it's at for type 1 diabetes. So we kind of look at prevention trials in 3 different stages. Stage 1 is where you have 2 or more positive antibodies, so the same type 1 diabetes prior to any hyperglycemia. Stage 2 then is when you have mild beta cell destruction and silent hyperglycemia. Stage 3 is when you start to have significant beta cell destruction symptoms. And this is where really on a research front, things are at to try and help prevent this progression to help either prevent or delay the onset of type 1 diabetes. There's been some pretty exciting evolves recently. So in TrialNet, teplizumab is a specific anti-CD3 monoclonal antibody that can delay the onset by about 2 years. There's also some work on kind of thymogen, ATG for preserving more beta cell function. And there are some other studies looking at hydroxychloroquine or other kind of immunomodulators to try to help both prevent diabetes as well as, if you're newly diagnosed, prolong that honeymoon phase for easier to control diabetes. The last thing as well, especially talking to many of you in the Middle East, is genetic testing for diabetes. So again, there's a third version of diabetes. It's not type 1 or type 2 diabetes. It's monogenic diabetes, so maturity onset diabetes of the young. I was just talking to Dr. Asma Deep over in the Middle East, and she was talking about how in her families, there's so many more with MODY due to consanguinity families than we have typically here in the United States. It's autosomal dominant diabetes for the most part, and it's 2 to 5% of patients with type 1 diabetes may actually be MODY. And what's exciting is they can usually come off insulin for most types of MODY. When do we think about MODY? We think about it really if it's a child that's presenting with an antibody negative type 1 diabetes. So if it's any child less than 10 especially, and their antibodies are negative, I'd really think about testing for MODY in this child. If there's a very strong family history of diabetes that doesn't necessarily quite match the body habitus or the adiposity of the family, mom had gestational diabetes, grandma has diabetes, great-grandma had diabetes, especially if it seems like it's kind of inherited in an autosomal dominant fashion, we often think about MODY. Other things, like if you have just kind of asymptomatic glucosuria, that could be very specific to one type of MODY. Another one is just fasting hyperglycemia only. So MODY2 or glucokinase is just a different set point for insulin release that manifests as just fasting hyperglycemia, and eventually the insulin will kick in, but it's just at a different threshold. And then I also think about diabetes when there's diabetes plus other stuff. So depending upon the versions, there's renal cyst or hearing problems or cardiac problems. Then we start to get more into these other kind of monogenic versions of diabetes. And the reason that we test is that depending upon many of them can respond to other non-insulin therapies. Here at Mayo Clinic, we do a gene panel for patients. It's about 45 genes. And then we can know pretty quickly if they do or don't have one of these genetic forms of diabetes. I always tell my patients that there's a good chance we may be negative, there's a good chance they may still need insulin, But if they're antibody negative, I think it's worth a shot, because those patients that you do find that could be able to come off insulin altogether, it's very exciting for all of us when we do find those patients. So with that, I'll thank you for your time, and thank you very much for our diabetes team. I can't say enough how it really takes a whole team to manage families and kids with type 1 diabetes. So specifically diabetes consultants, which are Division Chair Dr. Seema Kumar. We have certified diabetes educators and nurses, fellows. We work with social work and psychology, as well as a strong clinical nutrition team. And we couldn't care for these children without the whole team. So thank you again for your time. It's been a pleasure talking to you today.